Hi, thanks for the opportunity to talk at the conference. I am a paediatric ENT surgeon and I developed a Paediatric Airway skills course in New Zealand, which I'm going to talk with you about today. So the concept for the course was that as a junior registrar, you start covering on-call roster from day one, which means that you're called for airway emergencies when potentially you have no skills, no experience, and limited or no training. And I think with any kind of airway emergency, the stress created is very high, and certainly with paediatric airway emergencies, I think is something that most people don't feel happy about the experience because it is so stressful. And I think when I became a consultant, I think it was something that was quite unreasonable that we were expecting people to manage something that they had no training to do. So because these are low frequency events, the opportunity to practice or to learn is very limited. So I think the other concept that I think very strongly is important is that airway emergencies is a team sport. And to explain what I mean by that, I think as individuals we are generally very well trained, but when it comes to an event that's high stress and not something we experience frequently, it can be quite chaotic and outcomes may not necessarily be ideal. So what we're working towards is that in these situations we can perform optimally as a team. And because we don't have the opportunity to practice this in our day-to-day clinical life, simulation is a wonderful way to try and develop these skills. So I was just going to talk a little bit about the steps that I went through in developing this course. So initially I developed a framework in my mind of what I thought would be a good course to run. I did a lot of networking and had amazing people all around the world that I learned a lot from, people who were already working in this space and were doing amazing things that they were very generous in sharing. I also did a lot of development of my own personal simulation skills and knowledge, becoming faculty trained and doing all simulation training that I was able to access. So I think then the next step is thinking about who the course is being developed for and doing a needs assessment on those potential participants. And I use SurveyMonkey a lot for trying to get this information, and that works really well for me. I think gathering a lot of support for the course, so being enthusiastic and bringing people along with you who are willing to be involved and help you. And the big part of that is faculty, but also you have to develop access to a lot of kit, some of which will be quite specialised. And I think you have to have some kind of idea about how, from a financial perspective, you're going to be able to run the course in a viable way. Then I think you need to develop more specific aims and what content you want to cover in the course. The next step is running your first course and your pilot and having a good evaluation from all faculty and participants at the end of that, and actively trying to think about positively how you can make the course better. And then every time you repeat the course, you make changes based on that feedback and trying to always improve the course that you're running. So I think from a very general perspective, I wanted this to be a very hands-on course that involved opportunity to understand and know how to use the equipment and have some specific technical skills that they developed. I wanted them to understand what we would be concerned about, what are the red flags when they're making an assessment. And so from a clinical perspective, they knew what to worry about. I wanted them to be able to have some idea of applying this knowledge in emergency scenarios and really backing up the importance of teamwork and communication in these situations. And again, this was designed always in my mind to be a very hands-on course, so I purposely have avoided having any significant lecture component as part of the course. They have a lot of access to online learning, and I think we don't need to get them to sit in a room to provide that component of learning. So I thought a lot about the equipment, that I really want them to understand how to put it together, how to use it, how to hold it, when you might use it. So from this, you develop very specific objectives of what you want to cover in the course. And I'm not going to go through this specifically, but I think having very specific components and skills that you want to cover is the next step. So the way that I ran the courses, I got some really good buy-in from the training committee, ENT training committee, and the district health boards employing the registrars that I wanted to take part. I had support from the local, we have a very strong simulation team at Starship, and they had really good buy-in to be involved with helping run the course. We had access to a really great clinical skills centre, which is a non-profit course we were able to access for free. And we had really solid support from Storts, who provided loan equipment and always attended and were amazing at helping us run these courses. I always ran the courses with very low numbers of participants, and I think if you have too many participants, you potentially are going to have people standing and watching, and as a hands-on course, you really need to have people doing stuff the whole time rather than just standing watching. This involved a lot of faculty, and the ratio of faculty to participants was really high. The way that I ran it from a structured point of view was that skills stations were in the morning, and then application of skills, running scenarios, was in the afternoon. So participants I put in groups of 4 and generally put them in levels of similar clinical experience for those groups. The ratios of instructors were generally 1-on-1 or sometimes even 2-on-1 for the participants. Each block I ran in 45 minutes, and it was a very tight schedule, and you had to run really well with quick turnarounds and really quick orientation to each new task. So the skill stations that we ran were rigid bronchoscopy and foreign body removal. We also had direct laryngoscopy and difficult intubation, and this was run as a team with paediatric anaesthetists and paediatric ENT surgeons and lots of kit. We also had access to virtual bronchoscopy, which was developed by an anaesthetist at Starship, and was a really good practice for flexible endoscopy skills. We had, with some of our courses, access to virtual microlaryngoscopy, and my dear friend and paediatric ENT surgeon from the States came over and ran an amazing session with us using his 3D simulator. I also did quite a lot of tracheostomy skills, and I think tracheostomies is very specific skills and knowledge. So being able to run through this, including with a paediatric speech language therapist, and doing emergency scenarios. We also ran an Epistaxis station, and we developed a mannequin that had the ability to have both anterior and posterior bleeding. This station was always run by our rhinology team, and I think was really good experience for particularly the junior registrars. We had a surgical airway station, and I developed over the years a model that had a sheep larynx, because I think that was most closest anatomically to the neonatal larynx, and we used pigskin over the top and stabilised it with a swimming pool noodle. And featured there is David Vokes, who has always been incredibly supportive of our courses, and he was the person that invited me to do this talk from the course organising team. So in the afternoon we ran scenarios, and we had a very gentle pause and discuss model of teaching rather than full debriefing, just from a time perspective, and the feedback about these scenarios was very positive from the participants. We did a neonatal stridor, so unknown diagnosis at the time they were observing them. We did a new tracheostomy that was blocked as a scenario. We did a facial trauma in Resus, and we did, sorry, my photos have turned around, a post-tonsillectomy bleed. So I think my take-home messages for the registrar was really thinking about planning and having some skills and knowledge that helps them understand what's involved in getting ready to manage emergencies, really understanding the importance of communication and teamwork. So a few kind of thoughts about the course. I think it's really important for the registrars that no evaluation was involved, and that made it less stressful, and they were certainly more engaged, I think, because they weren't worried about being evaluated. I think understanding confidentiality and engagement is really important, and getting them to really feel that it's a safe space to be working in. I think having some form of consent, so you can use photographs and videos if that's helpful in future teaching, and the feedback, evaluation, and that continuous development and improvement of the course is key. So I think there's a panel later on that will have an opportunity to ask more questions, but I hope that's helpful in just understanding how I put this course together.